Yes, a very good morning and many thanks for staying with us right here on NTV Uganda. My name is Romy Busiku. I come to you yet again with another pertinent conversation, HIV and COVID-19 stigma. That's a conversation we're going to be having today with Professor Canon Gideon, team leader, spirituality, ethics and theology. He's one of the founders of the National Forum of People Living with HIV and AIDS Networks in Uganda, shortly known as NAFOPHANU. That is Professor Canon Gideon was one of the first religious leaders to come out publicly in 1992 to say that he had HIV and AIDS. Yes, that is very honorable. So he's with me here in the studio to talk about the HIV epidemic and also the COVID-19 pandemic. The COVID-19 pandemic has wreaked havoc on many jurisdictions, both on the economies and lifestyles of the individuals within those respective jurisdictions. I'm talking about access to antiretroviral therapy treatment. It has been hard for many of the COVID-19, for many of the HIV people within this country or the world. We do know that by 2020, 37 million people were actually grappling with HIV in 2020, and only 27 million people were on medicine. That is a milestone, by the way, because in 2010, only 7.8 million people were on HIV treatment as of 2010. So we've made milestones. But then the number of infections have continued to skyrocket, especially among young teenagers between the ages of 15 and 19. We've continued to see an uptick in the number of HIV infections that have been projected right here in Uganda. So why are we seeing a rise in the number of HIV infections being registered right here in Uganda and all over the world? We do know that the number of infections within the urban area have increased by over 7.1%. Yes, and 5.5% that is in the rural areas. Those are aggregations that came about when Uganda was grappling with only 72,000 cases of COVID-19 and only 680 people had died as a result of the COVID-19 disease. Now we are talking about 121,587 people with COVID-19, yes, and we are also talking about 3,099 people who have succumbed as a result of the same very heinous disease. So if we were talking about 7% of the urban dwellers having HIV back in the day and 5.5% of the rural dwellers having HIV, could it be that there's been an exponential increase beyond 10 or 14% among urban dwellers and rural dwellers? Yes, that's why I have Professor Canon Gideon to explain why there's an increase in HIV infections, especially among those young adults between the ages of 15 to 19. A very good morning. Thank you for joining us right here on NTV Uganda. It's a pleasure to have you.
Thank you, Romeo.
You are one of the first religious leaders who publicly came out to actually disclose that you had HIV. Could you please indulge the viewer with that little bit of history about yourself?
Oh, thank you. I'm a teacher by profession,
Indeed.
A pastor by calling, a theologian by training.
Indeed.
And in 1991, I lost my wife suddenly.
Sorry.
And I was in the theological college, Mukono, teaching, reverence. And then when they told me my wife had died of an AIDS-related illness, that sparked off an interest to go and find out whether I am positive too. And indeed, the tests confirmed my worst fears. I was HIV positive. And in that counseling room, the counselor asked me a question that has shaped my life. He said, "Man of God, what are you going to do?" And that was a very tough question. And I said, "Oh, okay, I hadn't thought about it. But the God who created me
has a plan.
Will give me a guidance on how to approach." And the first guidance I received was, do you keep quiet like the rest? Most people do, or are you going to talk about this disease? So I decided I'm going to talk and be public so that people can demystify some of the things they think about AIDS. Like AIDS doesn't attack everyone, it only attacks a few people who are deviant. I wanted to bring that face that helps people to rethink about what they think about AIDS. And I've done this work in 60 countries of the world.
60 countries in the world.
And I've founded the African Network of Religious Leaders, which is of people living there, of religious leaders living with HIV or personally affected. We are now in 25 countries, and we are 13,000 members. I went on to co-found with NAFOPHANU, as you have heard. We
in 2001?
2003, May.
2003, yes.
Yeah, May. So I've done some good work, including training young people, because I didn't want them to pass through what I have passed through. So we have what we call the Friends of Canon Gideon Hope Institute that trains young people. We have graduated 3,000. We pay 60% of their fees. And if you are very vulnerable, we give you a complete bursary.
All right, tell us about this fight against the HIV epidemic all the way since you started, engaging in these activities. Would you say that we've made strides when it comes to eliminating this epidemic, or are we seeing a downward trend when it comes to new infections taking center stage? In my preamble, I did say that many of the 15 to 19-year-olds are susceptible to new infections. That's what we are receiving. 38,000 new infections all to HIV, and the biggest chunk of those cases are going to young teenagers. And like I did also mention in my preamble, there is an increase in HIV prevalence in the urban areas, 7.1%, and rural areas at 5.5%. What could be the reason behind the increase in the HIV infections that we are noticing right now?
The increase in the infection rates could be around the new phenomenon of COVID.
The new phenomenon of COVID-19.
COVID-19, which has two impacts. One is, if your family has a person with COVID, then all attention focuses on saving life, and you forget any other comorbidities that people are struggling with. The second one is the interventions that have been put in place to control COVID have an indirect impact.
The lockdowns.
Yeah, the lockdown, the measures that curtail movement, remove staff from their work and say leave essential staff. All those have a bearing on what impact you are going to have on the ground in terms of safe practices, in terms of access to treatment, in terms of testing and counseling, and in terms of the practical activities going on in the villages, in the communities, to empower young people.
Go ahead. You feel uncomfortable with the mask?
Well, I can speak better since
there is social distance.
We have a social distance.
Indeed. So, in your respect, how has the COVID-19 pandemic affected this fight against the HIV epidemic, especially those who are living with the disease?
Well, it has interrupted the service delivery in terms of 5 elements that are critical for people living with HIV. Number one, your service in terms of information and practical goods, practical products that help you prevent AIDS or prevent transmission must not be disrupted. In the case for COVID, there was the issue of lockdown, don't move, don't cross districts, don't, and that interrupted people's access to both information and to products to keep their behaviors protected against transmission. The second one was, of course, around issues of treatment, that the impact also of lockdown made interruptions in uptake of ARVs, and nutrition, again, was a challenge, especially in the urban areas where people were struggling to have food, and taking ARVs became a bit risky, to say, I can't take ARVs on an empty stomach. Testing and counseling were disrupted. And of course, then the field activities, which we deal with young people.
Awareness creation.
We did in terms of awareness, in terms of skill building, in terms of empowering, holistic empowerment, spiritually, socially. The churches and the mosques are still closed.
Indeed.
So that's an impact also on how prepared young people are.
You see, the viewer who is watching this show is now wondering, urban centers are known to have to be very near health centers or health facilities. So why is it that those areas that are near health facilities are registering a higher infection rate as far as HIV is concerned, in contrast to their rural counterparts who largely do not have access to these services?
Nearness and access are two different things.
Indeed.
They were near before interruption. Now services are interrupted. You can't move. If you move, the services are curtailed, and also costs have increased because of the situation of COVID. So let's not talk about nearness. Let's talk about accessibility and affordability.
So because people in the rural areas did not have the health centers to begin with even before the pandemic. So the pandemic has hit. They're not even talking about access. They're talking about availability. There are no health centers to begin with.
Exactly.
But then still there is a low prevalence of HIV within the rural areas. So the viewer is wondering, why is that the case in contrast to the rural urban areas?
Because the difference is that the virus is nothing. The terrain is everything.
I see.
Yeah. So, like in the urban areas where you have the gap between those who have and those who don't, the levels of inequality are a factor in driving the epidemic. Whereas if in the rural areas where everyone is almost at the same rank, you know, but here where people have so much and others lack so much, there is increased vulnerability. There is that push and pull effect where people want to survive, and so survival for the day eliminates long-term thinking about survival for the long term.
It's just to do with prostitution, survival.
I wouldn't want to limit it to prostitution because the person who is having sex for a chapati doesn't think they are doing prostitution.
I see.
Yeah. The mother who is exchanging sex for food to bring home for children to eat, I don't think she would say I'm a prostitute.
I see.
So
she will justify it because she's trying to make ends meet.
yeah, I mean that's what is available now. I had a very unfortunate story, and it was not actually even in town. It was in the rural area in Bwambara, in Kigezi, where this woman was forced to sell her body to get what is this? Mapapari. Popos, yes, popos. And she brought them home, cooked for the food, the children, but she was crying all the time.
I see.
Until the elders asked, what is the problem? And she said the truth and said, look, I was forced to do this for the children, but I can't settle down. So we can't defeat new infections in the city if there is no multi-sectoral approach that looks at what are people feeding on, how are they moving from point A to point B, how are they catering for their daily needs to survive. How are you getting data on that phone?
Indeed.
How are you moving from point A to point B?
Indeed.
If the border says don't pay, what does that really mean? So I would really want people to be concerned with the urban settings, to ask the 5 vital questions that drive the epidemic.
Indeed.
Number 1, how are people doing safe behaviors and safe practices in urban setting?
Complacency has taken center stage.
How are they accessing and adhering to treatment and to good nutrition? How are testing services being provided and adhered to? And what are people who are vulnerable, the most at risk, the most vulnerable, the most impacted and the most burdened are in towns? So what services are around that group? And then the stigma. Again, the stigma seems to be biggest.
Yeah, we shall talk about that.
Yeah, in that. So these variables, the 5 variables, determine whether you are up to the task of ending AIDS, even COVID, or whether you are going to lose it.
Professor Canon Gideon Biamgisha, are persons living with HIV at an increased risk of contracting COVID-19?
Yes, it depends on, it's all the question of immunity. If the virus...
Because immunity is already compromised.
Yes, if the virus has already damaged your immunity, then surely your susceptibility to COVID is at a higher percentage. If you have HIV and another comorbidity or comorbidities,
Indeed.
then again your susceptibility to COVID becomes higher. Yeah.
One of the challenges that came to light during this pandemic was the stigmatization that was meted out on persons living with HIV and also those COVID-19 patients.
Yeah.
Help us understand how the magnitude of this problem that is eating our communities as a cancer.
Stigma comes in when people who are supposed to be helped are blamed.
Indeed.
Are blamed.
Why did you get COVID-19? Why did you get HIV? You did
Yes.
not put on a mask. You did not put on a condom.
Yes. This is a whole. So there are about 5 sources of stigma that are probably common to AIDS and common to COVID. The first one is fear around quick death. When you yourself, who is having COVID or having HIV, suspect that you don't have much to live, how much time to live, there is a way you behave. And if your family members and community members also say, oh, he's dying tomorrow, there is a way they stigmatize you and discriminate you and deny some privileges from you. All of that is stigma. And the way they respond can make it worse for you to cope. So you die early. Many people don't really die of AIDS or COVID. Many die of fear, many die of anxiety, and more of stigmatization, being blamed.
Well, of course, you were telling me about that story of a daughter before we started this interview, about a young daughter who went to her father, disclosed that she had HIV, but what did the father do? Instead, he bought a coffin. 4 days later, the young lady was dead.
Yes.
Go ahead.
So that's number 3 of the source of stigma.
I see.
The first one is fear of quick death by both the family and community members, but also the person.
Yes.
The second one is fear of contagion. When family members and community members feel you may infect them, then they exclude you. They distance from you.
Of course, a misconception, because HIV does not get spread through air. But of course, this used to take center stage. That's how they get stigmatized.
Up to now, people fear to have a communion, Holy Communion, among people who, if some Gideon is known to be positive, they will say, well, I will take the Holy Communion tomorrow. Except now that people have changed the... But even
that's where we go to ethics, spirituality, and theology.
So attitudes die hard.
Indeed.
That people can stigmatize you even if there is absolutely no risk.
I see.
But because of that fear, that unmerited fear, that can happen. Then number 3 is what you are causing. People associating your infection to something bad. Is God punishing you? Is God judging you?
Because of your risky behavior.
Because of your risky behavior. And people who use the behavioral approach to medicine and health, they will say, oh, you have COVID because you didn't wear a mask. You have COVID because you didn't keep social distance. Without really analyzing this whole issue of the slum areas, we are actually keeping social distances.
10 people in a single room. Very, very hard to social distance, and it's a reality.
Yeah. But even if you wear a mask, will you keep on a mask when you are sleeping with your wife?
No.
Will you keep on a mask when you are eating?
No.
So these are issues that the behavioral approach fails to see, that and ends up stigmatizing people who should have been supported, people who should have been empathized with. And then the 4th one, and probably most significant for this talk, is the messages we put across.
Indeed.
If you say abstain, if you can't abstain, be faithful. If you can't be abstinent and faithful, then use condoms. And then Gideon says, I'm positive. What do people conclude? What do people conclude?
Go ahead, Gideon. That if Gideon cannot keep himself safe, then who am I?
Gideon didn't abstain. Gideon was unfaithful. and he was even too stupid to wear condoms. So what?
So the judgment.
What type of leader is this one? So when people hear that, then they keep away from identifying with anything that will show that they have HIV.
So the messaging coming in from the religious leaders also has played a part in increasing the stigmatization we've been seeing against persons living with HIV.
It's not
in
only
terms of
religious
theology,
leaders.
ethics, and spirituality.
It's not only religious leaders.
Go ahead.
It is also the public officials, the community leaders. Everyone says ABC. AIDS is as simple as ABC. So help us defeat AIDS. Do A, do B.
Because I was doing the People's Parliament in Kabale and we talked to some of the religious leaders. This is what they said. They were saying abstinence is the only key. They were saying contraception shouldn't be given to any of the young teenagers. And then I posed a question to one of the religious leaders. What if the perpetrator is my father or my relative, a breadwinner whom I cannot just leave and run away, someone who is taking care of my food, pads, and everything, my well-being? So such a situation whereby a girl is being taken advantage of by someone who is supposedly supposed to take care of them, what do they do? Do they continue to abstain when someone is forcing themselves on them in case they become pregnant, or what do they do? Can they take a contraception pill? Go ahead. The messaging coming in from the religious leaders.
Messaging, when it assumes a self-righteous stance, and you put yourself on a high platform morally, and you look at others as
indeed
sinners who must be converted, then you fail to look into the dynamics of case by case. You fail to get such cases like what you are explaining to be handled, and that's where the ethics comes in. What you believe about God and about human beings will reflect into how you relate and help them. So you find that people who have a self-righteous stance will blame people more
instead of helping them.
Will listen to them less. Will empathize with them rarely, and support them none. Whereas people who have a theology like God is love, God is gracious, God is kind, God is compassionate, those will tend to listen better. They will tend to find a way of helping people, even when they know that probably the person did not protect themselves enough. They will not judge you. They will just extend help because you are a human being. You have a right to human dignity. So I think we need to interrogate into our messaging. Why do we have messages that focus on individuals at risk
and not the factors that may lead to the risky behavior?
Yes. Why don't we have messages that focus on what my religious leader, my president, my LC5 should do? Like now, wear a mask. People think that's the responsibility of the individual at risk. But apart when I meet an LC5 chairman and I want to talk about soaps, what should he hear or she?
Where are the masks?
How much is in the budget in your LC5 budget
to distribute masks?
To buy and distribute masks. Right? How much is in your budget for sanitizers for those homes that can't afford sanitizers?
When they say it is upon the households to procure these items, it becomes an individual fight.
Yes.
I see what you're saying.
Yeah, so there must be a societal response to, like we have common goods, we should have common problems.
Indeed.
That must be attacked as a community. And you cannot attack something as a community unless you have a community message, a community philosophy. Because it is the philosophy that generates the passion. It's the passion that brings the policies and the programs and the partnerships and the training programs and the finances to tackle this problem.
The viewer who is watching might actually be stigmatized, but they just do not know the different forms of COVID-19 and HIV stigmatization. Maybe if you could break them down for the viewer who is watching, the different forms of HIV and COVID-19 stigma. How does it manifest, this stigmatization?
It manifests in various forms. Of course, there is the societal stigma that people abandon you, shame you,
family, yes,
discriminate against you, exclude you.
Number one.
But then there is the self-stigma,
Yes.
where you feel guilty, you isolate yourself,
This is of my own doing. I should isolate myself from the community.
Yes, you blame yourself unnecessarily, you worry and die, not because of the virus, but because of your too much stress and depression.
Indeed.
And but I've also explained also that the types and the sources correlate. If there is if you are stigmatized because the members are feeling you are dying so soon, then the solution is understanding that actually when you have AIDS you can't die fast if you are on treatment, if you are accessing care, if you have the love that you need. You become like a Gideon.
Indeed.
You live long,
Indeed.
not only long, a productive life, and not only a productive life, you join in the struggle to prevent an infection.
From 1992, Gideon Yamgisha is still here, pretty much, and very, very healthy. Go ahead.
So
adherence is key to the medication.
adherence is key. But knowing the source of the stigma helps in stopping it.
Yes.
If it is around blaming people because of their behavior, like now we have people who are in the adolescent age group,
15 to 19.
yeah, being more positive, and we are also seeing them unable to prevent infections from mother to child. That means that there is a stigma around delivery of services.
And even information to our teenagers.
You know, I'm including service has 5 elements.
Multifaceted.
1, information.
Right.
A service to provide accurate, adequate, and timely information. That's a service. A service to change attitudes to be appropriate, so that people can identify with risk. You know, that's a problem.
Indeed.
If you feel there is no COVID, you won't take measures. If you feel there is no AIDS, you won't take measures. So a service to change the attitude, and a service to provide skills.
Indeed.
A service to provide skills, products, but also the most important, a service to provide conducive laws. Conducive laws
and policies
that do not stigmatize, shame, discriminate, exclude.
The National Sexuality Education Framework.
Yeah, that's an example. But also we have like the ending AIDS. There is a law about deliberate transmission.
Indeed there is.
Which misses deliberate acquisition and puts all the burden on the person who is positive and doesn't put the equal burden on the person who is negative. You know, so there must be laws that are fair to everyone and are accurate and adequate.
And it makes matters worse when the same health workers who should be advancing these health services to our young people are the ones actually discriminating against them or stigmatizing them. You are 15, you are 19. How come you need contraception services? Is that the reason why we are still here? Early teenage pregnancies increasing, young people falling prey to this fight simply because the people they should be running to are stigmatizing them, the health workers.
Yeah, and you see that's something I've been arguing for a long time, that when we talk of religion, we tend only to think about people who are in religious leadership like me. But there are many people who are professionals, they are health service providers, but they use their religious lens in providing or withholding a service.
All right, we shall compound more on that conversation on the role of the health workers moving forward after this very short break. This is a conversation largely focusing on HIV and COVID-19 stigmatization that has taken center stage within our country. 1.4 million people are grappling with this disease in this country. 1.2 million are on treatment. So where are the 200,000, especially the men? Many thanks for staying with us right here on NTV Uganda. 37 million people all over the world are grappling with the HIV disease. That's what we do know. In 2020, only 27 million were on treatment. So 10 million people were not receiving antiretroviral therapy treatment. And that could only lead to a regression when it comes to the fight against this HIV epidemic. Well, of course, we also do know that in Uganda, 1.4 million are grappling with the disease. Only 1.2 million are on treatment. So where are the 200,000 people? We also do know that in 2020, 690,000 people died as a result of HIV and AIDS-related illnesses. That is in 2020, all over the globe, not only Uganda. We also do know that the UNAIDS organization, the UN agency, is actually working hard to ensure that they cut down on those cases of number of people who are actually dying as a result of HIV from 690,000, yes, to all the way to 250,000 by 2025, 4 years from now. And the infections are from 1.5 million in 2020, those were the new infections in 2020, all the way to 350,000 by 2025 in 4 years. Can that be achieved? I still have Professor Canon Gideon Byamgisha. He is a team leader, spirituality, ethics, and theology. He is also one of the founders of NAFOPHANU, that is the National Forum of People Living with HIV and AIDS Networks in Uganda. Very good morning once again.
Thank you.
You are still here with us, and we are still continuing with this conversation. Largely when we broke off, I was talking about the 200,000 men who do not want to get tested to know their status for HIV. The viewer would like to know, why is it that men are adamant to seek testing as far as HIV is concerned? Why do they not want to know their status in that regard? And what could be done to get many of these people into the fold when it comes to treatment?
Again, it is connected to the stigma we've been talking about.
Stigmatization.
Yes.
I don't want people to laugh at me.
When you say abstain, if you can't be faithful, if you can't use condoms, and the man fears that if I go and test and I'm found to be positive, the people will blame me. And so, but even when they get courage to say, let me test, when they get the results, many of them don't disclose. So it doesn't help in two ways. It doesn't help treatment. It doesn't help preventing infection, because the spouse or the partner should really be in the know. But many men hesitate to disclose. And when they do disclose, many of them do it too late. Too late for prevention, too late for treatment, effective treatment. So we lose in both.
So that is the effect of the stigmatization.
We lose on prevention, we lose on treatment. And that's why we have a phenomenon of deaths that are really not necessary. The people in my faith world, people tend to think that all deaths come from God. But there are deaths that are coming from ourselves, because either we do nothing, we call it inaction, or we do things in a way that makes the problem worse, misaction. So we have a duty really to help the men by removing the stigma out of the virus, enter their world and design messages and intervention programs that fit their world. 200,000 is not a big number, and if that 200,000 is the one causing us problems not to move far, we could target, we could do what we call targeted prevention, targeted response, that is saying we want to find these 200. Where are they? How do they live? How do they have their sex? How do they, move from point A to point B? What makes it hard for them to access? If, for example, they are border drivers who can't afford to put the border down and go for testing, can we do it? Can we do the testing after they have finished the border?
I see.
Yeah. Can we take the testing center at the parking place and make it so comfortable?
The doctor going to the patient.
Yes, the doctor going to the patient. Because, sometimes they are at the waiting stage and they probably take like 10, 20, 30 minutes before they get another customer. But if the service is near and is confidential enough and user-friendly enough, people will say, I still have 30 minutes, let me go and test. And then there should be a mechanism of helping them to disclose. There are other people like men in uniform. Men in uniform need a way of, a new way of looking at their life and seeing how we can make access to information, to skills for prevention and for treatment, better. So we should, if we can really do two things. One, remove the blame game and say it's not risky behaviors that are driving the epidemic. It is rather the risky environments that people operate in.
Yes.
And then we focus on those environments. I was sitting on the task force that was supporting presidents to come up with the political declaration in June, the one that came out in June. And most of our focus was to look at the inequalities and injustices around access. That if we can remove why people access information and others don't, why people access skill building and others don't, we could do much better. Like now we have in Uganda, we have a big problem of NEET. I don't know whether you have heard of that, NEET. Young people, they are not in education, they are not in employment, they are not in training. So where are they getting their information and services from?
I hear you.
They are nowhere, and they are big, a big number.
But we've made strides, Professor Canon, Gideon Biamgisha, when it comes to getting more people on treatment. We were talking about 27 million people on HIV treatment. That is over 2020 last year. In 2010, that number was around 7.8 million people worldwide on treatment. So in 11 years, we've been able to add 20 more million people, 20 more million people to actually get more help as far as antiretroviral therapy treatment is concerned. But then the number of infections have increased. We haven't been able to put a halt to the number of infections being registered, because in 2010, we did have some 2.9 new infections. You understand? But in 2020, we're talking about 1.5 million new infections. There's only a 500,000 reduction in the last 11 years. So we wouldn't say that we've made strides in that position. And another development pertains to the fact that most of these infections are among the young group, 15 to 19 or 15 to 45 years of age. So that's another callous development. So many of the recommendations are that maybe it's because the young people do not have enough information on the epidemic, on the disease, and so forth, on what needs to be done if you get in risky situations. Maybe you've been raped, you don't know that there's a PEP drug, you understand? You do not know that there's a contraception pill to stop a pregnancy. But then there is a group of people who know better, 45 to 49. The older people, and these are the people who are infecting our young ones between the ages of 15 to 19. Intergenerational sexual encounters are the reason why we are seeing so many HIV infections among the young ones. Would you agree?
I do. I do, because of, and that's why I said that let's not focus on the behavior. Let's focus on the environment that produces the behavior.
The environment has still given...
For example, the whole issue of patriarchy, that a man is entitled to sex.
Yes.
And the woman is not a human being, is a sexual object. So don't ask me about condom, don't ask me about... actually, you don't...
I do what I want.
You don't even have a right to ask. That's the patriarchal world, sexist world.
Yes.
So unless you tackle that toxic masculinity, you will not go a long way in reducing the defilement cases. You will not go away in marital rape. You will still have problems. So you need to go beyond AIDS and look at the cultural paradigm that is existent. That's why in religion we're also tackling our own theologies and ethics and spiritualities that we think could not be helpful, and we are trying to interrogate them and come with better paradigms. So you need to do more than... That's why I said we need to stop the blame game. The first thing is to acknowledge that we have a problem, and the problem has multi-sectoral roots. Not only multi-sectoral, even multi-level things. There are problems at the community.
The viewer who is watching would understand that, okay, well, it is a teenager, they got involved in risky behavior simply because they did not have information. But a 45-year-old who knows everything about the risky behavior leading to contraction of HIV, and then they still continue to have sexual intercourse with these young teenagers without Yes, condoms and so forth. So you're talking about people who are deliberately spreading the disease, yet they know better. What could be done to avert this situation?
By tackling the whole issue of lovelessness.
Lovelessness.
You know, we have three things that are driving problems, not just AIDS.
Three things.
But also, you know, there is lovelessness, there is self-centeredness,
I see.
and then there is self-righteousness. If you don't tackle these, because the self-righteous person will blame that young girl instead of supporting them to say, let me stop the risk, let me reduce the vulnerability. The self-centered one will say, as long as I satisfy what I want, as long as I get what I want, I don't care what happens. You saw that gentleman who killed the young girl at campus by saying, mugulira nti esimu ate najikubira kwa balala. You know, that has to be stopped. That self-centeredness, that selfishness has to be tackled.
Of course, it took center stage also in the COVID-19 pandemic fight, when you did have young people who were saying, me, my immunity is way up there. I do not need to wear a face mask. It should be the older generation wearing those face masks. And that led to a resurgence of the COVID-19 disease because they didn't know the variants had come around, mutations, and they were affecting young people also. Go ahead.
The self-centeredness is everywhere. With the developed world having all the vaccines they need.
Thank you.
And for us struggling to have the second dose or even the first dose.
Yet they are talking about a third dose. Wow, very heinous.
So, yeah, you know, AIDS, me, I'm a person who brought a new way of looking at things. Not the only one, but one of those people who say AIDS is not just a disease. The same thing with the COVID. COVID is not just a disease. It's a symptom of the things that has gone wrong in the way we live with one another, in the way we relate with one another, and in the way we trade with one another. So until you fix those three, you may not get a big headway. Why do epidemics start in developed countries, but are soon contained, and then the problem comes unresolvable among the
availability and access.
Among you know, the epidemic of AIDS started in America, if you remember. It was the epicenter. Now, this Christmas, this December.
But they were telling us the DRC in 1920.
This December.
That's where it started from.
This December 1st, they are going to celebrate the end of AIDS. I was there in 2012. They were celebrating the end of AIDS from mother to child. Now
they're talking about 40 years since the first case was registered.
We need to question, why is it that the countries that are struggling with literacy, that are struggling with the nutrition, that are struggling with the education dropouts, that are struggling with corruption, are the same that have high rates of disease? Not just disease, but preventable disease and controllable illnesses and non-inevitable deaths. You know, why should we deal with a specter of a 5-year child dying or a 40-year person dying? People are supposed to live to their full.
And could that be the reason why in Africa, because of the health systems that are really, really very, very weak, is that the reason why many people are dying because of AIDS-related illnesses and not the HIV itself? Comorbidities.
Yeah, many things are happening.
If I have cancer, tuberculosis, and so forth, I'm going to be killed by the cancer and tuberculosis and not the HIV itself.
You listen to the speeches from our public health officials or governors when they are talking about epidemics. You would expect them to say, this is what we are doing around safe behaviors and practices, the policies, the budgets, access to treatment, testing, empowering young people, the vulnerable groups, and tackling stigma and discrimination. Very few people go there. What do they do when they are given 5 minutes to speak? They say, mwekume. So a person,
but the how aspect is not being
a person gets the impression
interrogated.
That, a person gets the impression that actually at state level we are fine. It's only at the individual level where there is a problem. Yet we know that most of these things are health systems related. They are related to the budgets of the money we are putting across to fight AIDS and to fight COVID. So we have the science, it's enough. We know what works, whether with COVID or with the AIDS. What is lacking is the will to translate what we know into good programs on the ground that are task focused, they are results oriented, they are inclusive, because if you leave people out, and that is tomorrow we are launching the SDG goals, the Sustainable Development Goals for Uganda again, but the big issue there is no one should be left behind, no one should be left out. So if you have a program and you know that the most at risk to AIDS are being left out, the most sexually active are not being targeted. I've been telling my fellow religious leaders that actually, when we talk about sex, we shouldn't even be talking about the young and old. No, we should be talking about the sexually active and the abstinent.
Yes.
Because you find in the young group people who are even more married than the old ones. They accept that they are married when they are in your home. Meaning they have more sex than a married person has. So you don't use the word of young person. A young person in what? You should be using
sexually active.
Sexually active. Because you'll find sexually active even in the 90, 70 age group. But you find someone who is abstinent across young people, middle, even, you know, they're abstinent. Some are abstinent by force. Others are abstinent by choice. The same thing with sexual activeness, that some are sexually active by force, by the conditions around them. And others choose to be sexually active.
Let's talk about political will. The UN AIDS Executive Director, that is Winnie Byanyima, she says HIV is still unfinished business, by the way. And she also contended that we need to do more to ensure that we do not focus only on COVID-19, but also the epidemic, HIV. When you actually write it off an epidemic, you call for a resurgence in HIV infections in that regard. She also did mention that we are on track to eliminating AIDS-related deaths, mortality by 30%, that is by 2030. Do you actually believe we do have what it takes to actually achieve that goal by 2030, given the projections I gave you, that 690,000 people died last year, and they only contend to cut that number to 250 deaths by 2025? So is it feasible?
It's very feasible.
Are you sure?
It is. We have the science to do it.
1.5 million infections
just
in 2020.
To make sure that you reach 95 by 95 by 95 by 2025. 95% of Ugandans know their status as negative or as positive.
Right.
Okay? Do that. After that, 95% of those who are positive, put them on ARVs. Okay? Do that. That's an unachievable target.
Been largely go ahead.
95% of those who are on treatment, make sure that they are on undetectable viral load. So where will the deaths come from?
Indeed.
It's as doable and achievable as you hear it. The only problem
implementation.
Is, do we have the will? And that's why I said, let's first deal with the blame game. If you look at AIDS as a disease of those who have willed to get it, as those who are choosing to be deviant, you miss the point.
Professor Canon Gideon Businje, do you believe that lack of political will is the reason why we are still grappling with this AIDS epidemic? Because some people, especially Winnie Byanyima, said if we could accord the same political will towards COVID-19, the same political will and the severity, the seriousness we've shown COVID-19, we could have been able to get a vaccine or even a drug for the HIV epidemic. But the problem is lack of political will to expedite research to actually look for an HIV drug. Would you believe that to be true, that if we put too much focus on HIV? It's
lack of a societal will.
Societal will.
Politicians respond to what people are demanding.
I see.
So where will you get the political will if no one is asking? If no one is in the rallies NAFOPHANU has been arguing for 10 years to say, when a politician comes to look for votes, ask them, may I know how much money you are putting on promoting safe practices? May I know how much money you are going to put on access and adherence to treatment? May I know your policies around testing?
Indeed.
May I know your policies around empowerment? And may I know your policies around stigma and discrimination? Once there is a bigger societal will, the religious leaders are demanding attention to AIDS. The young people are saying, you must deliver. There is no way the political will refuse to come.
Indeed, we have 5 minutes left, and the HIV patients or people living with HIV who are watching need some recommendations in that regard. What advice do you give people who actually are fearful that maybe they contracted HIV during this COVID-19 pandemic? And also, what advice do you give to those people who have HIV already, but they fear they may have contracted the COVID-19 disease during this pandemic?
Thank you. That's a good question. One is really to re-examine the fears, and if they are gaining fears, seek treatment, seek help, medical help. If it's not medical help, look for peer support. At NAFOPHANU we have a helpline, available. You can ring anytime
for psychosocial support.
Psychosocial support to address your fears, to address your worries, and also to connect you to the right service. Like when there were interruptions of medicines, we had people who would help people to take medicines, those who are unable to get them. So that's the first point. If you are positive or if you fear to be positive, seek help, get support. NAFOPHANU also has a telephone line which you can call 0701 44448.
Yes.
Very easy number to
701 call 4444, that's 48.
Yeah.
Those are 5 4s and an 8.
Yes.
Go ahead.
You can the helpline is 080 100 330.
All right.
And if you want to write, it is info@nafophanu.org.
Amazing.
If you want to check their website, go to www.nafophanu.org.
Before I let you go, what lessons can we learn from the response of the HIV and AIDS fight in response or with regards to cabbing, stigmatization and discrimination? What lessons have we learned from the response to the HIV and AIDS fight?
Number one, we have enough science. Science works.
Of course, lessons from HIV to cap stigmatization.
Number two,
in COVID.
Number two, you cannot defeat AIDS or COVID unless you defeat stigma and discrimination. Number three, it needs focused leadership that is intentional, that is task focused. We call it total commitment, not a mere contribution, but total commitment. Number five and last, gender issues. If you can look at the gender issues and the vulnerability around the most at-risk populations, you do it. And for us in the region, we say, if you do what we can, God will do what we can't. There is much in our history to give us hope and courage. So let's do what we can very well. The safe practices, the access and adherence to treatment, the testing, the empowering the vulnerable, the eliminating the stigma and the discrimination, and then you will see miracles. We end AIDS, we come here to celebrate the end of AIDS. It's possible, end inequality, end AIDS.
Amen. And on that note, we've come to the end of this conversation. Thank you very much, Professor Canon Gideon Byamgisha, for having made the time to speak to us.
Amen.
It's been amazing.
Thank you.
And very insightful.
Thank you.
Indeed, he is one of the first religious leaders in 1992 to have come out and disclosed his status as far as HIV is concerned. Yes, he's one of the founders of NAFOPHANU, the National Forum of People Living with HIV and AIDS Networks in Uganda. Yes, we do have some 37 million people who are grappling with this disease, 2.7 million who are on medicine last last year. We need to make more strides in ensuring that more people get onto treatment and reducing the number of infections that have largely taken center stage among young teenagers between the ages of 15 and 19. Also, COVID-19 stigmatization needs to be done away with. The COVID-19 survivors need to be embraced. That's the only way we can be able to beat this epidemic and also the pandemic, which is COVID-19. My name is Romeo Busiku. Have yourselves a blessed day. I return shortly with NTV at 1. Keep it here.